Thanks for the invitation. It's always great to be here. So these are the potential conflicts. So of course, we're talking about aortic dissection. It comes in two flavors. Obviously, type A is obviously a little more worrisome than type B, but it all starts with the formation of some sort of intimal tear, and then you have blood propagating in a dissection plane through the aorta. It's always also important to note the features of all the layers, because there's actually a lot of activity in terms of TGF-beta and matrix metalloproteinases at the media level. So there's a lot of activity not only at the intimal level but also the medial level. These are representative pictures that I think we all see and understand. So in terms of type B dissection, you can see, as in contrast to type A dissection, the mortality is substantially lower with medical therapy. It's unacceptably high in type A at 57%, but in this study, 8.7% is actually better than either medical or endovascular for the management. The other thing you see in the graph is a trend towards more management of these with endovascular grafts. So while medical management remains the mainstay and surgical management is low and declined, the endovascular management has started to pick up. In terms of outcomes of trials, you'll see that if you look at all of these and pick a median number, the median number for mortality for medical therapy is 7%, as opposed to 16% for surgical therapy and 6% for endovascular repair. And that's what's led to guideline recommendations. So in the US, essentially uncomplicated aortic dissection is treated with medical therapy, and that carries a 1B recommendation. The ESC, and then in this particular review, has also included endovascular repair at a somewhat lower level grade, but it's at least now being mentioned in the mix as a potential therapy. So in terms of conservative management, I think obviously we want to look at predisposing conditions, so hypertension, particularly uncontrolled, is a problem. Tobacco with its atherosclerotic promoting activity is also an important predisposing condition. But lifestyle is interesting, and the reason why I say this, isometric exercise makes sense. I don't know how you avoid excess stress, although we do know of some patients who have changed professions, changed jobs to avoid stress. But the last one, screening for illicit drug use, and I don't know if this is just because I'm from Oklahoma, but I'm routinely shocked by the age of people who test positive for methamphetamine. We have in our mind that it's sort of a young person's problem, but it's shocking to see 57, 63, 64-year-old people who test positive for meth. So I think you have to always assume that, and not assume that everyone's using it, but just check. Don't assume that they're not. So in terms of medical management, the object is first of all to reduce the wall tension on the aorta and stress, so that's achieved with beta blockers with a target systolic in the 100 to 120 range, and preferably a heart rate of less than 60. Now, verapamil and diltiazem can also be used. There's some data to support their use, but beta blocker therapy is number one. In terms of other management, so you want to reduce afterload, but you want to do it after you've used beta blockers. So ACE inhibitors have not shown a mortality benefit, but they obviously do help with lowering blood pressure. They also have some sort of activity in lowering tumor growth factor beta and some of the MMPs. And the reason why that's important is there's MMP 8 and 9. There's actually a screening test for that, and for patients with acute aortic syndromes that has 100% sensitivity. It has awful specificity, but it's interesting as a test. And MMP 2 and 9 are probably the most well-known of the MMPs that break down connective tissue. ARBs may in fact be better than ACE inhibitors because they don't just lower TGF-beta, they inhibit TGF-beta activity. And then vasodilators, if you need them because you're having a lot of trouble with blood pressure, are useful, but you do not use those first. If you use them first, you may inadvertently increase the wall tension and stress on the aorta. So that's sort of a last ditch thing. And not because I'm excited that Game of Thrones is coming back July 16th, which I am, But I think another thing that we always forget about is pain management, okay? Blood pressure medicines do not get rid of your pain. So this isn't the time to withhold pain medicine. You need to control the pain so that you help decrease the sympathetic drive that's associated with pain. So in terms of the evolution of how endovascular therapy has come about, I think this really shows it, because in the first, even up to 48 and 72 months, depending on if you're looking at all-cause death or aortic-related activity and death, you see that the curves are fairly similar, but then something happens beyond, in terms of long-term follow-up, that widens these curves. And it's, if you think about it, it makes sense. I mean, the aortic dissection may have healed, but that's not a normal aorta. So it sort of makes sense that over time, maybe these people continue to have problems. So it led to these sorts of algorithms. So obviously the presenting episode, you want to admit, you want to have intensive medical therapy, you want to do some surveillance imaging. But as you move forward, you are sort of looking at this like how you would treat an aneurysm. So uncomplicated, but you're doing your imaging. So maybe at 6 weeks, maybe then at a few months, 6 months, and then annually. But you're looking for the features that would be similar to an aneurysm. So increase in the diameter, any of these other symptoms, you start to intervene, and at that point, the endovascular method is very useful. Then once you get out past 6 weeks, it's a chronic condition. So again, you're managing it and you're surveilling it in a chronic fashion, much like you would if it was an aneurysm. And then once things cross over into needing therapy, endovascular therapy is obviously a good choice. Thank you.